Good day, everyone. I am Dr. Jeimylo de Castro from the Philippines, and I'm going to discuss today the topic on neuropathic shoulder. So let me begin by sharing to you this book of inspiration found in Isaiah 40, 29 to 31. God gives power to the weak, and to those who have no might, he increases strength. Even the youth shall faint and be weary, and the young men shall utterly fall. But those who wait on the Lord shall renew their strength. They shall mount up with wings as eagles. They shall run and not faint. So my disclosures are the following. I'm receiving royalties from Springer from this book, Advances in Chronic Neuropathic Pain. So anyone of you who's interested to learn more about this, you can acquire this book from Amazon. And also, I'm a speaker for Embascal Ultrasound workshops under Sonoscape Ultrasound Technologies. So these are my learning objectives. So understand the anatomical basis of neuropathic shoulder and its associated pathologies. Recognize the key relevant structures on the shoulder implicated in various neuropathic shoulder conditions. And evaluate regenerative injection therapy such as alpha-2 macroglobulin exosomes that is suitable for addressing different shoulder pathologies. And of course, explain the methodologies and applications of ultrasound imaging in diagnosing shoulder pathologies and assisting in interventional procedures. So let me begin by citing to you the epidemiology of this condition. So shoulder pain is the third most common MSK problem with negative impact on the quality of life. As you can see, we see a lot of patients with shoulder problems, but the question is, have we encountered conditions where, in spite of all the treatments that we have done, still the pain persists? And we could just be facing this condition, which is referred to as the neuropathic shoulder, because it has a frequency of about 10.9 to 15.8% based on the study by Balta and Peckens in 2023. So the prevalence of radiologic shoulder osteoarthritis is estimated to be mostly asymptomatic. So about 16 to 20% did not show any symptoms, but these are found among the middle-aged and elderlies. And usually the cause is because of joint damage affecting the cartilage, wherein there are proteolytic enzymatic action that were released in the joints. And 5% to 17% of these conditions are symptomatic with shoulder complaints. So patient would come to you with shoulder pains, and that is why they would like to you would like they like them to uh, let them assessed by you. And so there's a neurogenic basis of neuropathic pain in the shoulder. So as you can see, the shoulder is innervated by three major nerve supply. We have the lateral pectoral nerve, the axillary nerve, and of course, we have the suprascapular nerve. Now, let me begin by citing this study on the anatomic sites of origin of the suprascapular and lateral pectoral nerves. Now here, if you will notice, it both arises from C5 and C6, with the suprascapular nerve emerging from the uppermost portion of the axon. And of course, the lateral pectoral nerve emerges from the lower portion of the C5, C6 roots. And so you can see here that this primarily arises both from these two root level of the brachial plexus. So the suprascapular nerve is a unique nerve because it has a longer route, and in fact, it comes into play when it actually enters into your scapula through the transverse scapular ligament, which is located both above or the supraspinous fossa, and of course at the supraspinous fossa at the sphenoglenoid notch. And so you can see here that initially it arises from the upper level, it emerges into your supraspinous fossa here, and then it goes into your infraspinous fossa, passing through a groove here at the spine of the scapula. And so that is how these nerves comes into play as it innervates the supraspinatus and infraspinatus muscles. And then, of course, by ultrasound, what you can see is that you see that echogenic line here, which is the transverse scapular ligament, and it's actually deep. Okay, so we're imaging here the topmost portion, and so you can see here the suprascapular nerve on this area below the transverse scapular ligament, with the notch below representing the lateral to medial area. And so when you actually inject this part, you come from the top, and then you can puncture into your trapezius and supraspinatus muscle into the nerve. So this is the location of your should I say the suprascapular nerve. Then these are different approaches that you can see here. So you will notice here the posterior coracoacromial ligament, okay, the anterior coracoacromial ligament right here, the conoid ligament, and then you can see the relationship of this to this ligament, how it actually emerges and passes under the transverse scapular ligament. So very, very interesting how it all emerges right here. And then the approach that we see using this angle here, where the needle punctures into that site where the suprascapular nerve is located. Then, of course, we have your lateral pectoral nerve. In contrast to the suprascapular nerve, the lateral pectoral nerve, as mentioned earlier, comes into play and also arising from C5 and C6. But as you can see, the medial pectoral nerve is way below, which is coming from your C8 and T1 and is connected through C7 by what we call the ansa pectoralis. And so as you can see here, from C5, C6, the lateral pectoral nerve emerges, okay? And then it is usually located between your pectoralis major and minor muscle. So again, here, this is your lateral pectoral nerve. Again, this is how it is related to the coracoid process. So medial to the coracoid process is exactly where this is located. And then if you check the ultrasound, this is your pectoralis major, and this is your pectoralis minor muscle. And usually these nerves are found in between these two layers at this fascia here. So usually the lateral pectoral nerve is more lateral and the medial pectoral nerve is more medial. And so if you actually inject into this area in between these two muscle layers, then these two nerves are found to be located in this area. You can actually uh, dissect that just by injecting into the fascia layer. So this is the pattern by which you can see the muscle here, the pectoralis major, pectoralis minor here, major, minor, and you can see here the images that you see in the MRI. And histologically, this is also how this is seen from the dissected area of these muscle layers. Then, of course, we have the axillary nerve. So you can approach it in two ways. You can approach it posteriorly. So you can see here the teres muscle, the deltoid muscle here, and then you can see here the axillary nerve muscle below. And then, of course, the biceps, should I say, the humeral bone here on this side. And so when you uh, approach the needle, as shown here in this approach, you can see that the needle from superior to inferior comes into play, and then it targets the axillary nerve. So again, to take a closer look, you can see here that the quadrilateral space is bounded by the teres minor above, then of course the teres major below here, and then of course we have the long head of the triceps, and we have the lateral head of the triceps right here. So the nerve really comes here. So again, this is another view. This is your deltoid. There is your teres muscle, and then the needle approaches the nerve like this. Again, this is another view of an approach whereby you approach the axillary nerve from the anterior portion, actually in the axilla, And so you can see here all the muscle layers, the biceps, teres minor, then the deltoid, pectoralis, and latissimus dorsi muscle in relation to the location of the axillary nerve. Again, this is posterior, this is anterior of the axillary nerve. Then you can see the relationship of all those muscles. So usually what I do is when the shoulder is abducted, you can see here the location, the brachial artery or the axillary artery is found at the middle, which is actually right here. Then, of course, towards the lateral portion, we have the median nerve. Then, of course, the 3 o'clock position is ulnar nerve. 6 o'clock position is the radial nerve here. Then the musculocutaneous nerve is over here. And then, of course, you scan all the way down, okay, from that position. And then you can see these layers. And then this is exactly where you can find the quadrilateral space and where the location of your axillary nerve is located. Now, a typical problem in the nerve supply is that when there is a pathology of the nerve, this is how a pathologic nerve looks like. There is a constricted portion of the nerve. This is the swollen portion, and this is the healthy portion. So as you can see here, the nerve is constricted, and so it's tight. And so this is a chronic constriction injury here, where the pain is actually felt, especially when patient has a neuropathic pain. And of course, there is a nerve nervorum that also supplies the nerve itself. There's a nerve supply that goes to the nerve itself, and that is the one that is actually uh, sensing the pain. And that is why the nerve itself would have its own nerve supply, but at the same time send signals that we can feel when there is something wrong with the nerve itself. Now, a usual pattern of nerve, as you can see here, this is a swollen part on letter B. Letter C is the constricted part, and this is the normal nerve on letter A. And so you can see here that it is well delineated, goes through with the pattern here in the ultrasound, but this one is very much diffuse. In other words, there is a lot of inflammation that's going on in this area. As you can see, it's also this similar with the ultrasound findings. And then this is the constricted part of the histology of the nerve. And then this is also how it appears in ultrasound. So you will notice that it's very consistent, whether you're talking about the nerves of gross findings, comparing it with a pathologic histologic problem, and of course, ultrasound findings. So how do we diagnose? So we can use these tools for neuropathic pain assessment for the shoulder using the LANS, the DN4, or the pain detect. They almost overlap their symptoms, and so you can use either or any of these tools to diagnose your neuropathic pain. Then here, for neuropathic shoulder assessment, one thing that is very, very prominent in these patients is that when a patient comes to you and you're not sure about whether you're dealing with a neuropathic shoulder, just the normal, probably frozen shoulder symptoms, you tend to give anti-inflammatory drugs first. But over time, maybe more than 2 weeks, the patient is not responding. So the patient would say, okay, the pain is still the same. I've been taking non-steroidal anti-inflammatory drugs and no response yet. So maybe you should start thinking about maybe this is something different. The pain is usually more than 3 months, and the pain could be preceded with or without trauma, and there is a tingling and numbness of the entire right upper limb. So this is typical of the neuropathic shoulder. But if you look at it, it could also be overlap or mimics that of cervical root problem. So for example, the tingling and numbness could actually point to a more proximal lesions of the plexus or the root level of the cervical spine. What is interesting here is that from the onset of pain to the diagnosis, according to this study, it takes about at least 2 years. Imagine the amount of time it takes for you just to get the diagnosis. And another similar period, almost 2 years again, from the diagnosis up to the referral to a pain center. So can you see how much time we waste to make the treatment and the diagnosis? And that is why high suspicion for neuropathic conditions are required in order to suspect that perhaps if the patient is responding to NSAIDs or even physical therapy, something might be wrong. Although you know that there may be some tendinosis or maybe rotator cuff tear that may be present, but this could be relieved with treatment with anti-inflammatory drugs. But the moment it persists, and you can see that there is a pattern of tingling sensations and pain, persistent pain, in spite of that, then it's maybe time to think about other things. So what are the anatomic, physiological, and biochemical basis of neuropathic shoulder? So here, there are pro-inflammatory cytokines in the rotator cuff. For example, you can see a lot of interleukin-6 and metalloproteases in rotator cuff tears. In fact, another study says that matrix metalloproteases 1 and MPP13 contributes to the deterioration of shoulder joint function. So if you have this and this, that means your shoulder joint function is deteriorating. MMP13 otherwise is decreased in large tendon tear. So if there are large tendon tear, and matrix metalloproteases 13 may not be present at all, or it may be decreased. And then, of course, for those with higher risk of rotator cuff tear and with an elevated could be an elevated interleukin 6 associated with an increased RCT risk. The interleukins could be requested as part of the cytokine profile test, which includes all of these pro-inflammatory cytokines. And then, of course, interleukin 1, interleukin 6, and TNF alpha are elevated in subacromial bursa in patients with rotator cuff tear. Interleukin 1 beta and interleukin 6 are the ones associated with more severe pain. And then, of course, its effect on the collagen type 2, for example, which is actually responsible for compressive blood absorption, is the one that is affected with the presence of interleukin 6 and it converts into type 3, which makes it reduce its ability to absorb compressive loads. Of course, the one that usually is that could be studied is a type 2. But the moment it converts into type 3, then its ability to absorb those loads will be decreased. And of course, there is also an increased expression of calcitonin-related peptide CGRP in the dorsal root ganglions in RCT. Now, the real culprit here actually is the nuclear factor kappa T cells. This is what they call the master switch for inflammation. Did you know that with this NF kappa beta, it controls the expression of all the pro-inflammatory cytokines which we have mentioned earlier, the interleukin 1, interleukin 6, and TNF alpha. Now, what is interesting here is that this particular molecule can be activated by oxidative stress, reactive oxygen species, trauma, injury, high fat, and high sugar diet, chronic stress, and poor sleep. In other words, when we treat patients, we should also observe some lifestyle factors that might contribute to the disease. So check for high fat, high sugar diet, or the presence of chronic stress or poor sleep, because in the presence of this will be elevated, but at the same time, with the elevation of NF-kappa B cells, it could also trigger the release of pro-inflammatory cytokines, interleukin 1, interleukin 6, and TNF alpha, which might lead to and is associated with neuropathic pain. So full thickness tears are more at risk for tear enlargement than partial thickness tears. There are always new pain with new tear enlargement. Okay, can you imagine that? In full thickness tears, it has 38% to 61% enlargement within 3 years. And then, of course, 22% enlargement in 2 years, enlargement in 5 years. So you can see the progression of these tears once it remained untreated. Within 3 years of diagnosis. So the longer we wait for that long without any treatment, the tear will really, really enlarge. So has 11% enlargement in 2 years, 35% enlargement in 5 years. So that's based on the study Calding and Keener. So rotator cuff tear facts, 20% of the population have RCT. It is present in 20% to 54% of persons aged 60 and 80 years old. and 30% of the population more than 60 usually has a full tear of one rotator cuff tendons, regardless of the activity of the patient. So what are the imaging options? Now, of course, we usually always say MRI is better than ultrasound, but in this study published in different researcher, you will notice here that ultrasound for partial tear and MRI, look at that. This one is 21 for ultrasound, 18 for MRI. You can see the superiority of ultrasound here as compared to your MRI. And for complete, you can see that they are almost the same. It's almost 9 here, complete tear for MRI, complete tear for ultrasound uh, images. So you can see here that you can rely on the use of ultrasound, although it's always user dependent, but provided it's the same, the quality of the images are good, the one doing it are all competent, you can rely on the results. So this one is the ratio that we always use in order to check if the patient has an infraspinatus teres minor ratio, which is normally 2:1. Now, we use these some prognostic factors to determine if a patient with, let's say, a rotator cuff injury is a good candidate for surgery. Because if it approximates 1:1 ratio, for example, for infraspinatus and teres minor, then functionally after the surgery, the patient will have some challenges because the infraspinatus has actually atrophied, and that functionally he might not be able to support the strength that is required for patients with uh, post-surgery treatment. And that is why here it's very important to also show should I say, a panoramic view of this muscle from supraspinatus to infraspinatus about teres minor. And then you can see here that this side on the left is normal, but this side you can see fatty infiltration with atrophy here of the infraspinatus as compared to your teres minor. So here, very significant change, if you will notice that. There's an increased echogenicity on the right. So tear-related factors that affects healing. So tear size of more than 5 centimeters with 3 or more tendons involved. So that will affect healing. Fatty infiltration of degeneration. This is an independent risk factors for non-healing. So if you have this, then there is an increased risk for non-healing. The presence of muscle atrophy, of course, is also an independent risk factor for non-healing, especially the presence of a tangent sign. And tendon delamination, you don't quite see this because it follows the normal lamination of the tendon. So sometimes you can only see this the moment you inject. There are times when you see a patient with ultrasound findings which seems to be normal, but the moment you inject it, you can see it open up. The fibers open up, and you can see the tear in between the layers. So it's representing about 32% to 82%. So this is a separation of 10 layers, and it correlates with tear size, retraction, rotator cuff repair, and healing. Tendon retraction length, if it is more than 22.2 millimeter retraction with muscle atrophy, it is associated with tendon non-healing. So usually, if I have like more than 2.2 centimeters, I usually ask the help of a surgeon because I know it would be very difficult to push through the regenerative treatment with that size of more than 2 centimeters or 2.2. Post-operative stiffness, 89.5% is associated with non-healing versus 18.2% if there is no stiffness. And then, of course, if there is fatty degeneration, it could be because of the suprascapular neuropathy or impingement of that nerve innervating the shoulder. So again, a very good example of both the long axis view and short axis view of the fatty infiltration. As you can see here, there's an increased echogenicity with absence uh, of patterns of striations here, as you can see in the normal tendon here in the teres minor. You can just see here a very increased amount of fatty infiltration on this side, and also as shown here in the long axis view of the tendon of the muscle. if you talk about diagnosing tears, you will notice here that it is very important to always begin your scanning where the RC tears usually occur. And so I would say the rotator cuff interval is the most common site of the beginning of tears. So here, this is very common site to check for your rotator cuff tear, and that you will be able to see the details of whether you're dealing with an abnormal shoulder or not. And then, of course, in a typical shoulder scanning, you can see here the bone, and then, of course, you can see here the apex of the proximal humeral bone that actually separates between your supraspinatus and your infraspinatus. And the reason why this is very significant is because this peak here tends to rub against these tendons, and that is why the tear is more commonly seen on this area because of the presence of this. If you do a dynamic motion, you can see it sliding on these two in these areas here where the muscles supraspinatus and infraspinatus is located. Now here, you can see here the full thickness tear of the supraspinatus. As you can see here in this video, you can see that here is the supraspinatus, it is the infraspinatus, and this is the peak here, the apex. You can see here that there is a complete tear on this area of the tendon. Okay, so you will notice here that there's a contour defect, there's a hyperechogenicity, there is a irregularity of the cortical layer. So this really speaks more of a complete tear of that area. So enlargement of RCT. Enlargement of asymptomatic RCT is common and is observed within 3 years of identification. Symptomatic RCT likely to have tear enlargement than those symptomatic patients. So factors contributing to tear enlargement. So unilateral risk of rotator cuff tear on the contralateral side. So we sometimes wonder using this right side, by what is it that this is? The other question is, at what age should we expect to have these findings? 48.7 years is the average age of patient without a rotator cuff tear. Out, okay? And then 58.7 years is the average age with a unilateral tear. So by the time we're close to 60, we can see this happening already. And 7.8 years, average age with bilateral rotator cuff tear. So this is the average age we can have a bilateral, so right and left tear of the shoulder. This is a very interesting. There could be a 20% tear. Now, the key is that there is a 2 to 5 millimeter tear progression over a certain uh, month period. And what is like 25% tear, we can still do your PRP treatment, but hopefully not steroids, because as you can see, steroids can induce an additional fragility of the tendons. If there is a 50% tear, then we can use bone marrow concentrate or even adipose stem cell treatment here. And only when we reach 100% tear should we do surgery, okay, according to this study. Factors that could affect RCT healing. Of course, if you are more than 70-year-old, this is an independent risk factor. The other thing is smoking. It is dose and time dependent. 29.4% is associated with non-healing rates. Obesity is also associated with fatty degeneration, with a BMI more than 30 kilogram per meter squared, with 28.6% of non-hearing rates. The presence of diabetes as compared to those with who are non-diabetes is, look at this, 23.3% versus your 15.1%. The presence of hypercholesterolemia, where there is an increased fatty degeneration, and it inhibits tendon healing. Can you imagine? That's why lifestyle change is a very important role in the healing process of patients, in spite of what we do in terms of treatment. 45.5% non-healing rate versus 11.3 if normal cholesterol. So that's a big difference. Exposure to vitamin D, 5.9% revision surgery with low vitamin D compared to 3.7% if it's normal. The presence of osteoporosis, it is higher with 6 by 6.6% versus 4.5% if you are normal. The use of anti-inflammatory drugs. This one is a COX-2 inhibitor. If you give it post-op, there is a 37% of non-healing versus ibuprofen, which is only 7%. So again, the choice of medications is also important in helping the patients heal. And of course, the steroids, we know that it increased risk of non-healing. And to some extent, there is also tear that could happen if injected in the tendons. For degenerative rotator cuff tears, the tear size is the most important predictor of infraspinatus degeneration. It's also the strongest predictor of symptomatic humeral migration, usually beginning at 175 millimeters squared. Increased tear size will lead to fatty degenerative change. So degeneration to really happen. That's why it's always good to know that if you have a tear, check the posterior shoulder, check the teres minor, infraspinatus teres minor rate, and see if he's a good candidate for surgery. Disruption of the anterior supraspinatus tendon was the most important predictor of supraspinatus muscle degeneration and greater tear size. So if there is any problem with the anterior supraspinatus, then we should really look into that. In ultrasound, so if you have faulty stairs, you expect it to have fatty degeneration all the time. Conservative treatments prior to surgery, of course, makes use of physical therapy. Some, again, use dexamethasone. I just mentioned this just to complete the information, but and we don't usually do dexamethasone because we know that it leads to tendon rupture. It's actually correlated with increased risk of revision surgery. And of course, orthobiologic treatments are the ones that are advantageous, especially for small and medium-sized stairs to prevent re-tears, but not, of course, for large stairs. So the orthobiologics, the role of regenerative treatments. So again, we always start with drugs, but as you can see here, these are the typical drugs that we normally use: NSAID, paracetamol, neuroleptics, SSRIs. Now, all of this, if you're giving this, would not respond to the treatment, to the condition, I would say. So if we would be your SNRIs, as you can see here, duloxetine and venlafaxine. Then, of course, your gabapentinoids, which are your gabapentin and pregabalin. These are your first line. And if you just not, it is actually second line in treatment for peripheral neuropathic pain only. So it's very, very specific for which indication is best treated. So interventional guided intervention procedure around the shoulder. So PRP still is a good treatment because it accelerates the healing in partial tears and degenerates. So for full tears, but only for partial tears. And so you can see here the different orthobiologic treatment for RCT, leukocyte-rich PRP to be treated with good outcomes, leukocyte rich also choosing towards peppering technique because you would like to induce more, uh, uh, should I say, it triggers the release of growth factors when you do the peppering technique. And of course, this will enhance the healing of the area that is affected by the tears. And then, of course, the critical review of regenerative for shoulder cuff. During the initial stage, PRP is very, very important. And it is characterized by increased vascularization and cellularity within 4 weeks post-treatment and fibronectin production. So these are just the different concentrations of PRP, as you can see, 10 times, 5 times more. We always prefer the one that has a greater concentration. So comparative study between platelet-rich plasma injection steroid. Again, a PRP is superior to steroids in mild to moderate shoulder osteoarthritis. Now we have, of course, your A to M. So this is alpha-tolin is concentrated up to 6 times to 8 times concentration, which is the one that enhances recovery and regeneration in injured nerve. It suppresses neuroinflammation, alters the course of peripheral injury. Now, specifically, it has the ability to actually inhibit pro-inflammatory cytokines such as your interleukin-1 beta, interleukin-6, and TNF alpha. So these pro-inflammatory cytokines are inhibited by alpha-2 macroglobulin. So this is the way it's being processed. So it filters about 0.5 microns here to about 1 micron. So going back and forth, you kind of filter the uh, platelet per plasma, and then after that you put it on the photonic chamber with a red light here for 20 minutes, and then it's ready for injection, as you can see here in these patients. Macroglobulin has a role in neuroinflammation, and of course, although it has a very low evidence yet at this point, it is considered to be one of the potential treatment for nerve injuries, in this case for pudendal neuralgia or thoracic outlet syndrome. And but as of the moment, it's not yet a standard care treatment for a lot of patients. But there are case reports and systematic review use which compare alpha globulin with other treatments. And in this case here, this is a patient with uh, below-knee amputee suffering from recurrent pain for almost more than 6 months. And then we started treating this with PRP. It's not working. And then we shifted to macroglobulin, where in this case we see results that the pain has reduced and has significantly disappeared over 2 to 3 weeks period after the last treatment. So this is an interim injection of the shoulder. As you can see, in a 56-year-old female patient, we injected the patient over the supraspinatus. And so you can see here that the fluid goes into the layers of your supraspinatus tendon. Now, the same holds true here for this approach at short axis view of the A to M supraspinatus tendon. And then also use that for the joint space, posterior glenohumeral joint, okay, in these patients with shoulder pain, with adhesive capsulitis, actually. And so we see that it has responded very well to these particular patients. How about for A to M for nerves? So here we were approaching the axillary nerve. And so we were doing it from the posterior layer at the quadrilateral space. And so we inject the A to M on the axillary nerve for shoulder pain for these patients here. And then we also use this for axillary, should I say, for sciatic nerve treatment for back pain. And then we also see results in this particular patient. Here is the suprascapular nerve injection using A to M. So let me see if this runs. Okay, so it goes all the way to the sphenoglenoid notch, okay, with the transverse ligament above it, and then this is the nerve below. So we injected the ATM on that site for suprascapular nerve hydrodissection. And then, of course, we also did that for the lateral pectoral nerve. Okay, so it's between your pectoralis major and minor. We injected the fascia layer in between those two muscle layers. Okay, not necessarily targeting on specific nerve, but here we injected in between the layers of the muscle. Okay. Now, other treatment that we use, of course, are the exosomes. Okay, that is derived from the adipose tissue. So this is a new approach that we use, and it also shows some promising effect, showing some anti-inflammatory, anti-apoptic, and pro-regenerative effects on rotator cuff tears. And this is used to prevent muscle atrophy and decrease in secondary biomechanic properties. So exosomes are said to be the body's phatic system. It is released from the cell when multivascular bodies fuse with the plasma membrane. So scientists who are doing research for this notice that exosomes they play in cell-to-cell signaling can also merge with and release their contents into cells that are distant from their cell of origin. So, for instance, there are other areas that could be affected, but we don't know yet. So it could also be have an effect on those pathologies from other areas. It also obtained from platelet proplasma and, of course, from micronized fats. So, in summary, this neuropathic shoulder is an important condition which does not respond with normal medication and intervention, and so we have to check and see the presence of this condition. The use of ultrasound has proven to be simple and accurate way to differentiate the different conditions causing shoulder pain. And there is an ample time to treat a partial rotator cuff tear and must be considered before doing any operative procedure. And degenerative tendon disease, tendinosis, usually begins at the rotator crescent and may expand in size and location. A to M as a treatment option is a new modality that needs to be explored when treating non-traumatic shoulder neuropathic pain conditions. And so I would like to encourage everyone, if you want to learn more, this book published by Springer in 2022. I was a co-editor of this book, and then it is available in Amazon. And then next year, I would like to invite everyone to these conferences. We have lifestyle medicine conferences featuring Dan Buettner, if you know, Beth Freites, and other prominent leaders in lifestyle medicine. And we also have this convention here in 2026 for our first annual convention of the Philippine Society of Interventional Pain Physicians, featuring all these speakers. And then, of course, on April 2026, we have your second Asia Oceanic Congress on MSK Ultrasound and Regenerative Medicine. And then we have these speakers, Dr. Joseph Purita, Dr. Kontaro Nishi, Dr. Yon, Wesley Chen, Dr. Puli, Dr. Tolga, and myself. And of course, we have also in May 10 to 11, this is a chemodenervation workshop, all in the Philippines. So again, watch out also for our book, which is a clinical ultrasonography in sports injuries in Springer London with Dr. David Sifu. So hopefully we can release it this year. And I would like to thank you everyone for your kind attention. This is my email. If you have any question, you can just reach me here in this email. Thank you very much.